Postvention is a term that you might not have heard before, but in any conversation about suicide and suicide prevention, it is a critical topic to address. Simply put, postvention refers to interventions that are conducted after a suicide death to support those who have been affected, including loved ones, colleagues, and the community at large. And help provide a closer look at the concept today, we have invited Ken Norton and Marie Kluker to join us for this session. Ken Norton is a licensed independent clinical social worker with over 40 years of experience in the mental health field. He led the development of NAMI New Hampshire's Connect Suicide Prevention Program and has been appointed to numerous committees, commissions, and work groups at the local, state, and national levels. Marie Kluker is a clinical social worker specializing in older adults and family work. She founded and leads the Dementia Support Program in McLean's Division of Geriatric Psychiatry. Her clinical work provides group and individual psychotherapy to improve caregiver resilience and to support people living with dementia. Big thanks to you both for being here. Ken, you have been doing a lot of work over a lot of years in this area of postvention. Has the field evolved significantly during that time?
Absolutely. First, and thank you very much. I'm really honored to be here, and the other panelists have been fabulous. But when, there was a long time when postvention really wasn't a thing in terms of the work that was considered or how it impacted on the suicide prevention field. I have a lot of great examples of that, but I think that it has really evolved to be embraced. I mean, it's certainly part of the national strategy and has been part of the national strategy for a while. But when we first started to develop evidence-based and promising practices relative to what postvention was, when there was the first best practice registry for suicide prevention, their response to us was, we don't even really know what best practices are for postvention because nobody had been doing it. So it really has evolved and come quite a bit in the last 20, 25 years.
And Marie, from your perspective, what is the importance of postvention? Why are we having this conversation today?
Thanks so much, and I'm glad to be here. A lot of my work, although my introduction was about geriatric psychiatry, is about people handling grief and family members and loved ones. And so the postvention is really for those of us who are here and suicide bereaved. How do we keep people from risk themselves of mental health crises, of being at risk for suicide themselves? So it's really for the ongoing health of those of us who are dealing with the loss of a loved one.
And Ken, you sometimes describe suicide death as the proverbial pebble in the pond. Can you explain?
Sure. I mean, when you think about that pebble in the pond, that first wave is the biggest wave, and it ripples out from that spot. And typically, when we think about postvention, it's the family, it's the immediate friends that are most directly impacted by that first wave. But there's subsequent waves that go out from that spot that impact on other people too. And again, I think that's part of how the field has evolved, to look at the broader impact of postvention, not just on the immediate family, but on providers, on community members, on schools, businesses, et cetera, et cetera.
Do we have any idea about the size of the population impacted by suicide? Any broad strokes, statistics or perspective on this?
Well, it's an often talked about bit. And at one point, there was some research that came out that said that for every suicide death, there were 6 people that were impacted by it. And there was, lots of conversations and papers written about this. The reality is that there are many, many, many more people than 6 people directly impacted by a suicide death. And, and how that number, how far out that ripple goes from that pebble of a single death isn't really known. As we heard, as Anna said this morning, 50,000 U.S. suicide deaths in the past year and 700,000 worldwide. So certainly a significant impact in terms of the number that are impacted by suicide death.
Yeah, if I can weigh in on that, the numbers, and these are kind of guesstimates, but as the metaphor of the pebble in the pond is such a important one, because when we think about who's affected, that one or like around 6 people per death. That's a kind of the closest ripple, and that would be the category. They're kind of different categories. One is the bereaved, and that's the closest knit. But then you go out one and say like the affected. Those people are kind of personally affected, and that the numbers of that is something more like around 10%. So actually the start of the biggest one is just people who are exposed. So if we're talking about 50,000 people, the guess is something around 135 per death are exposed to the information about a death by suicide, and then of that 135, maybe 10% are affected. That might be not just family members, but coworkers, friends, and then that inner circle is the bereaved, and that might be more like 4 to 8. So certainly the effect is really wide, and it includes in also therapists, other counselors, and other helpers. Even first responders can be in those kind of closer, smaller circles. But we're really talking about something like maybe 6 million people are that exposed to the effects of death by suicide.
Given those numbers, I can't help but ask the question. It seems that communities are often unprepared to navigate the challenges that can arise in the wake of a suicide. Would you agree that that's the case? And if so, why? Ken, why don't you start us off?
Sure. Absolutely, that's the case. And certainly we have gotten much better in terms of how we think about it at a community level. But, starting with one of the challenges that we don't use the word suicide. And a lot of times we don't acknowledge that a death is a suicide death, or the family doesn't want to acknowledge that it's a suicide death. It's very rare that you see in an obituary that suicide is listed as the cause of death, although it used to never happen. And occasionally now we will see that. So, those part of it is just the unwillingness. I mean, first of all, as a society, we generally don't talk about death, right? I mean, so, we need to acknowledge that. And then suicide death comes with a whole complex array of stigma, if you will, or sometimes shame, blame, and other things related to how we as a society, we as people, culturally differences, how we react to it.
Anna, let me ask you this. We, in fact, I want to mention that we're trying to work in as many audience questions as we can today, and we've had some great questions come in already. And what is this? Any suggestion about the best language to use when creating community awareness of suicide? I want people to care about this message and not say anything that is going to scare people away from engaging around the topic. Let's talk a little bit about messaging at the broad societal level that comes with postvention. What are your thoughts?
Well, certainly, I mean, we heard this morning, and I'll repeat it again, but, we want to avoid terms like successful suicide deaths and failed suicide attempts. How that got into our lexicon is beyond me. I mean, we do not want people to die by suicide. And we do want people to use the word suicide, but how they use it is really important. We want the media to use the word suicide, and we'll talk maybe about that a little bit later. But we want, and as we've, I think, heard over and over again, talking about suicide is a significant strategy for preventing suicide. When we don't talk about it, then it becomes unspeakable, and that's really problematic. And we also heard that there's some objection to the term committed. I don't use the word committed because of what's been previously said about the ambivalence people feel. They don't want to live, but they don't want to die. And so, language becomes very important in terms of how we think about and how we engage suicide communities around talking about suicide.
Maria, let me ask you about who is most at risk of being impacted and most in need of support following an unexpected loss.
I think even before zooming in there, maybe a little bit further out is just kind of what are we, when we think about loss and grief and recovery from grief, there's kind of a few stages, and it's important because of like how kind of people sort out into those stages of grief after a loss, any loss, death. There's acute grief, and in that time, kind of people are, whether it's by suicide, whether it's by natural causes, whether it's by something like homicide, or a sudden death, an accident. There's some differentiation within that acute grief period, but those intense emotions, really lack of ability to function, that is all expected. The what ifs, and kind of those mental stressors, the stories we're kind of telling ourselves, those are really common no matter the death. And then with every grief, the hope is that we'll get to a point of natural relief. So there's a period of adaptation in which those, really intense symptoms start to wane. And the goal is to get into what we call integrated grief. Now, death is forever, and therefore grief is forever. There's no end to grieving. Of course, something like suicide, where it's a sudden, unexpected death, where also or maybe it was expected, but certainly something to be, it's a tragedy and highly emotionally charged. We would expect that acute grief to be pretty intense, but it is actually the case in which people do get to the permanent stage of integrated grief, where grief is a part of their life, but they also have a life around it. And they're able to connect with people, and they're able to find meaning and sources of joy in their life again. Whereas in that acute grief stage, in the very beginning, that is not even necessarily, what they're looking for. And we don't expect that. The point in which what we're looking, particularly for one of the risk factors that we're looking for people, are those who, from acute grief, are getting derailed on that adaptation phase into integrated grief, where they actually end up taking, a divergent path, getting derailed, and they end up in what diagnostically we call prolonged grief disorder, or also known as complicated grief and other things. And that's where, if we take the metaphor of a wound, with an open wound, at the very beginning, it's bleeding, you bump it, it's going to bleed again. That's acute grief. And then it heals, first layer of skin, and eventually we get a scar. This is more like a wound with time. Time does not heal all wounds, but in fact that they're still really not able to be connected with others, really difficult finding joy, and almost like an infected wound that's not healing. And so that's one of the things that we're looking out for, are folks who get stuck in grief. And for the general population, that kind of prolonged grief disorder, it might be something around like 6 or 10%. When it's a death by suicide, that number at least doubles, maybe 20% or more end up in that prolonged grief disorder. And along with that are higher rates also of depression in addition to grief. Also, so that's one thing for the bigger picture, which we can touch back on. But what we're also looking for is one of the differentiations of people with who are in high risk are folks for whom, within the experience of grieving a death by suicide, they feel and experience a high level of stigma around that it was by suicide. When that happens, the not just passive suicidal ideation, but actually active attempts at suicide go up significantly. So the more, to your point, Ken, that we're trying to destigmatize suicide, the better effect it has for everyone, including people's literally their lives.
So thank you, Marie. And you've just done a terrific job of kind of spelling out the specifics of that piece of postvention in terms of treating people impacted by a suicide. Ken, what are some of the other pieces, broadly speaking, in terms of what falls under that postvention umbrella?
Sure. And that was a great, explanation of how grief is different for people when it involves suicide. But just taking a step back, the general sort of goals that we think about for postvention efforts are really about reducing risk, as Marie talked about, and about promoting healing. And so it's really those two key categories, and reducing risk, because when we know somebody who has taken their life, we statistically become at higher risk ourselves for suicide. And again, there were references to a little bit about this morning about contagion and what we know about contagion. But want to say, first of all, contagion is real. It's been demonstrated over and over again. We've seen it recently with often celebrities.
Let's see, Ken, do we still have you? It looks like you, there we go. We lost you for a minute there, Ken, if you want to back up in maybe 30 seconds or so. Okay. Marie, are you still with us?
I am.
Okay.
Yes.
Let's talk a little bit about contagion while we regroup with Ken and get his line back in place with us. What do you want us to know about this concept of contagion? Maybe even define it for us first.
Mm-hmm. Yeah, contagion is, as Ken was saying, a very consistently seen phenomena where after a death by suicide, folks who have been, again, in those ripples, exposed to the fact that it was a death by suicide, that we see this effect of the number of deaths by suicide increasing in the time after that. And the reasons for that are many, some of them being that it sometimes, one of the reasons we're careful about messaging is that suicide can sometimes be kind of glorified in a way that encourages people as a kind of a way out. But what we know, as Ken was saying, is just it continues to be the case that after a death by suicide, there's an increase in the number following. And
so Ken, with you back now, let's go ahead and zero in on what you talked about earlier, which is the media component of all this. I worked in the media for many, many years, and I always appreciated the support that we would get from the suicide prevention community in terms of safe messaging and language that we should and should not use in our reporting on suicides, for example. What has been your experience over the years dealing with the media on this front?
Well, again, they've gotten better, but it's something we constantly need to work on. And I would direct people to reportingonsuicide.org, the standardized safe messaging guidelines, and I was part of working on that group that put them out. And really, again, as mentioned this morning, we don't want people to get into very specific details, the graphic details about how somebody died or the circumstances with which they died. We do want to talk about it from a public health perspective and provide supports for folks. So when I talk about some of the celebrity deaths, one of the things that we did know relative to contagion that was a positive offshoot was that when the media reported on the what was then the suicide prevention hotline, which is now 988, there was a dramatic increase in calls to that hotline number after some of those suicide deaths. So providing resources, providing supports, and directing people to where they can get help can be a really important part of safe messaging.
And anything else you wanted to add on that front? And I'm sorry, Maria, I saw you're nodding your head there.
Just to say that again, such a great point that you brought up, Ken, that when the positive part of the contagion effect is that being able to offer people resources and then they use them. That's really using the messaging to the advantage of people's lives and public health.
We turn back to some of the questions that have come in. And Ken, this is one for you in terms of language. Several questions about what language should be using have come in. Should we say completed suicide? How do we talk about someone who attempted to take their own life but did not complete a suicide? Again, precision of language. Do you have preferred terms?
Sure. I again avoid the term completed because I think it is very similar to committed. I think we can just say somebody died by suicide. or they died at their own hand. And I think relative to attempts, we can say it was a non-lethal attempt, to describe an attempt that didn't result in their death. So, but some of that becomes what sort of is comfortable for people, and sometimes I think we get overly hung up on. I think whether we use the term committed or not committed suicide isn't going to result in anybody's life being saved or anybody taking their life. But I think it's important relative to sensitivity. And when we're here talking about postvention, it can help promote healing for those who are left behind.
Marie, let me swing back to you here for a question about emotional fallout, which I believe is a term used by Dr. Anna Precht about the family impact of sudden, unexpected loss. We're often told that people grieve in different ways. Could you talk about how family members might react differently and how we can stay together during these times when those reactions might be different, causing some friction?
Mm-hmm. Sure. So, what was probably a common experience, that doesn't differentiate is this like high emotionality, intense emotions. But how that manifests for people, of course, is different. There can be, along the spectrum of, or all of the above in terms of disbelief and kind of acceptance of the loss. Certainly anger is really common. And it can be anger directed in many sources at the person who died, at people who didn't do enough, at one's own self, blame, and feeling guilt. And then also, as I talked about, that there's this natural trajectory usually towards integrating grief, but it happens at different paces. And there's often a question, even if one's kind of clinically on track, this question, am I grieving too much or am I grieving too little? And then this judgment of, are you grieving too much? You're you're not loyal enough to this person. And so I think messaging from a clinical side is truly helping people to focus on their own healing, that sometimes if we're judging other people's, that it's a distraction from our own. And a better use of emotions and looking at other people is to with an eye towards, are you coming back towards connection with other people? Are you able to look forward to things in your life? And if everybody's moving on a trajectory, in the right direction at whatever speed they're going, that's a useful investment of one's thought about other people's grief. Whereas judgment is probably not.
Again, I want to ask you a couple more questions about the broader picture of postvention. You have been actively involved, as we mentioned, at the systemic level, developing programs for communities, for example. What does it take to get a community to buy into the importance of postvention? And then how do you go about making those first steps to make that happen?
Well, one of the things that's important to differentiate is that when we talk about suicide prevention, we're looking to engage everybody in suicide prevention, right? I mean, we talk about often a gatekeeper model where we want everybody to know, like we all know, what the signs of a heart attack are. With postvention, it's a little bit different. We're really looking at focusing on the key responders who are going to respond after a suicide death and trying to educate them and get them to pull together to understand what the best response is at a community level, however we define community, whether that's a geographic community, whether that's a high school, whether it's a college campus, whether it's a tribe. And to work together around having a coordinated response. A lot of times we talk about late adopters, and those are the folks who may really not buy into, or may, in worst case scenarios, try and block an attempt to work around postvention education and bringing a team together around this. You have your people that immediately embrace it, and those are the people, obviously, that can really be a key in engaging community members. I think one key strategy is you look to get those people lined up first, and then you look towards how you can try to engage the late adopters and who in the community has a good connection to them. So I think sometimes what happens is when that late adopter or those couple late adopters are not there when you're pulling the community together to talk about this, their absence becomes very noticeable, and it creates pressure on them to kind of think about how they might get involved and to get involved. So it really is about a community effort. It really is about education, and it really is about communication. And I think, the other thing is, thinking sort of from that immediate, so it starts with, with law enforcement who's responding to the scene, and then funeral directors, faith leaders. Those are the folks that are having immediate contact with the family within hours, or if not at the scene, and how they respond. So really, looking broadly at sort of the key folks, emergency room staff, educators. Going out from there in terms of who's going to be involved in that effort.
And can I assume that there are some boilerplate starting points for building a plan like this, that you don't have to reinvent the wheel for each community if there are folks who are taking this in today and wanting to know about taking some first steps?
Yes, the Suicide Prevention Resource Center, SPRC, has some great toolkits generally for postvention, but there's also the U.S. guidelines for postvention, and they are, responding to a traumatic death, and were put together for a specific postvention response as part of the group that worked on that as part of the National Suicide Prevention Action Alliance. So there are definitely a lot of good guides for helping people to think about how to engage a community around suicide prevention efforts.
Right. Marie, you mentioned guilt, and we have a follow-up question for you on this front. Many of my patients, I assume this is coming from a clinician, struggle with a tremendous amount of guilt. How can we help people who are blaming themselves following a suicide?
Mm-hmm. Well, this is of course, a really common among people. And one of the things I think about with healing is, blaming oneself in the case of an event like this where you didn't have control is a way psychologically to feel as if I had control, and it's control over the loss of someone, as if I had control, I would still have them here. So it's also this kind of like seeking connection with somebody. And some part of the work of healing within grief, or moving towards integrated grief, is a sense of accepting that you didn't have control and that you don't have control now. And as well as trying to seek new ways of finding connection with the deceased person. And so part of the work in grief therapy is to try to elicit some of that, of creating a changed relationship with the person that doesn't have to do with when they were, or that is changed from when the person was alive. That way, I think about it as like swinging on, like Tarzan swinging through the jungle, is holding on to a vine, and to be able to let go of that vine, if that vine is guilt, because it gives me a sense of control and I feel connection, I need to hold the next vine, something new, to be able to let go of the first one. And so that's really where the work is in counseling. Where Ken, you're working on the more macro level, I'm very much in the micro clinical level. That's the work that we're trying to do, is what's the next vine to hold on to.
I'm so glad you described it in those terms, Marie, because I've been thinking that as you're both talking. Both pieces are so important, the micro and the macro. That they all fall under that postvention umbrella. So thank you for referencing that. We've had a number of questions come in about folks who would like to support a workforce following a suicide. What do you recommend, Ken, that a company might do to help support its workforce when they're impacted by a loss from suicide?
Well, it's not dissimilar to how you engage a community. And some of that needs to be that, hopefully that there are steps taken before a suicide death to have a supportive workplace environment, just generally, and to make connections for people, and to have them feel like whatever size organization that they're in, that they're a part of something and they're connected. Again, just sort of repeating, isolation kills and connectedness saves. And so what steps a business can take, I mean, is to, first of all, to be truthful about what happened. I think it's important that, getting back to that, we don't talk about suicide, to be honest about that it was a suicide death. And that's not a requirement, because sometimes families don't want it publicly known, and that's another whole dimension and a conversation we can have maybe in a minute. But the workplace can bring in counselors. There are often teams that will come, that can come in and help provide support, or there's their own employee assistance programs, their own, personnel and HR people, and to think about it not in terms of the short term. I mean, just the short term, because the short term is obviously important, but what's the longer term impact? And, some of the things you may want to do is to set up like a memorial spot, maybe the person's desk or whatever, their locker, but make it clear that at the end of 2 weeks or some set period of time, that you're going to take that down and give those things that were left there, those mementos, to the family. So you don't want to necessarily have something that's there permanently, but certainly allow folks to grieve, to maybe have some type of memorial service. And, and again, with that memorial service, like in the community, you want to think about how to honor that person's life without glorifying their death.
And we'd be remiss not to follow up that question with a question about a suicide that impacts a school environment, and anything that we should know about postvention planning on that front.
Yeah, I mean, again, really important, and previous speakers have done a great job talking about adolescents and the challenges that that adolescents face in terms of their own development and their peers, and so certainly teens are at much higher risk than the general population for contagion, and I think it's important to recognize that it may not just be that. That physical connectedness to a person, but it may be how another teen sees their relationship to somebody that's taken their life. So I got onto Facebook many years ago when there were no privacy settings, because we were seeing, after a suicide death, teens were posting things like, "I'll be with you shortly," or something that was really serious kind of warning, and it was, where are the adults in this space? And so I think that again, having memorial services, talking openly about it, and providing supports can be really key. Making whatever physical memorials time limited. But I think really the key here is to have a plan in advance that's worked out that you can follow, because many times in a school setting, the people that then are the decision makers are personally impacted by having known that student, or maybe another teacher. And when you can take the emotion out of it and have a plan that's already been established, it becomes much more effective at putting the plan in place than when you're in the midst of perhaps your own grief and your own feeling of loss relative to a suicide death.
And Marie, let me ask you a quick follow-up on that front. What would be a good way to communicate a death by suicide of a young person to friends and peer groups or schoolmates in the wake of a suicide?
I feel like that's a little bit more in Ken's court. Whereas I more receive people after they have the news. Ken.
Yeah, fair enough. Again, Ken, did you want to weigh in on that? And again, this kind of gets at the micro versus the macro. So I appreciate that response, Marie.
Sure. I think it's really complicated, and it's complicated by whether the family is willing to acknowledge that it's a suicide death or not. And it doesn't mean that the school can't still take some postvention response, even if the family won't acknowledge it, because there are many types of sudden deaths. There's homicides, there's medical deaths, there's car accidents that may befall a student or a staff member at a school. So there are certainly response steps that can be appropriately taken. But I think particular to that suicide death, and one of the things I would say relative to the family is that because of what we've talked about, shame, blame, stigma, the family may not want to acknowledge it's a suicide death. But when they do that, they become much more isolated. I think what we hear from families that do acknowledge the death is they had no idea their friends, their other family members who come forward to talk about their loved ones who have died by suicide that they didn't know about. So, so again, that connectedness piece can be really important.
And Marie, this question did come in specifically for you. I lost a client to suicide over 5 years ago, which has been devastating and painful and has affected my confidence in how I view my work. Would you talk with us for a moment about losing a patient and the impact it can have on us as healthcare providers?
Yeah, absolutely. It's a really good question, and one for which this clinician who wrote in is in good company, unfortunately. And both in having lost a client to suicide, but also in the struggle to get back. And I think this is very much highlighting how someone not a family member, but is still in this like very affected circle of the ripples. And that this is real. And so that really this is a grief and a loss to be honored and to be healed. Just because you weren't family doesn't mean you're not grieving. And it speaks to kind of the same principles of grief. And I would direct folks to prolonged grief therapy out of Columbia University that actually has a really strong protocol that is much beyond, sometimes people go into grief therapy or kind of depression therapy when really what we need is a specific grief therapy. And this has, very high efficacy through NIMH studies. But one of the steps that I encourage for this clinician is what we're looking for is some acceptance, of course, of the death, that you didn't cause this death. But moving towards a vision, a future state where you can imagine that this patient has a place almost like of rest within you and your memory of this person, and to restore your own sense of purpose. And also what is often lost in grief is a sense of competence. This is not just because you are a clinician, but actually, many grievers feel this even if they were not in a place of power. And also, encouraging you for us find places of community for connection in hearing a me too. I've been in that position and me too. But certainly, it sounds like 5 years out, there's space for the really again robust and helpful steps of complicated grief therapy or prolonged grief therapy out of Columbia would be a place I'd turn.
Thank you. And I would just add that a resource for folks is the Coalition of Clinician Survivors. It used to be a listserv from the American Association of Suicidology. If they Google that, and again, from a post-vention perspective, organizations, inpatient units, outpatient programs should have protocols in place for supporting staff and how they would respond to the death of one of their clients. Much more difficult on the individual practitioner level, but as Marie said, very important that people deal with this and often not acknowledged and not talked about in our professions.
As we sort of wrap things up at this juncture, I want to give you both an opportunity to sort of speak to the hope that's afforded through this post-vention work and suicide prevention in general. I know you've both been involved in this field for a long time. And let's leave our viewers with some hope in terms of the work that's being done. Ken, you want to start us off?
Sure. I mean, I think that, one of the things that I am most hopeful of is the creation of 988 as the national 3-digit hotline number for people to get help. And that includes post-vention assistance. And to get connected, most of those are answered at the local level and people can get connected with local resources. I would urge people that have lost a loved one to suicide to consider connecting with other loss survivors. And I think that we have come a long way in the last couple of decades in acknowledging the importance of talking about suicide, death, and supporting people, all people, including first responders who have been impacted by a suicide death.
Marie, any closing thoughts?
Yeah, I think in this, we certainly, in acknowledging a death by suicide, we think about that person with compassion of what they must have been carrying, and how hard that life had been for them. And I think for those of us who are alive, we think about in coping with a death by suicide, this internal belief, I hope that we communicate, that we can do hard things too. And in doing that, that we who live carry this sense of meaning and purpose, that we can support each other, that we find can while attending to our grief, can find a way to use that to empower, to kind of give us fuel towards being connected to one another, and again to offer care to one another.
Well, thank you both for those thoughts. Thank you both for your time. What a fabulous job you've done helping us understand the importance of postvention as a key piece of suicide prevention. We very much appreciate your time today.